So the next presentation is by Dr. Alexandrov, Thrombaspiration of acute embolic SMA occlusions.
Thank you. I'll be fast because the first two presenters actually cut my presentation by 2/3, so there is not much to say anymore. But I have no conflict of interest. But from diagnostic, we have to do something for those patients. We have to treat them. I will be brief in these slides, but okay, it's not a common disease, but it's really deadly. Actually, it's one of the deadliest diseases because the mortality rate is over 50%. So it's a real problem, although it's very rare. Of course, the risk factors for acute mesenteric ischemia and thrombosis are advanced age, smoking, some prothrombotic entities, and most common valvular diseases and cardiac diseases that are have linked to some kind of thrombosis, ventricle or in the left atrium, atrial fibrillation, ventricular aneurysm, and sometimes, very rare, I've seen one case actually, right to left shunt with persistent patent foramen ovale. So again, typically affects older patients with atrial fibrillations and atherosclerotic disease. They spoke very for the out of proportion pain, which is the typical symptom. The CT is the gold standard, and about the treatment, well, it's really not easy to make the decision, because that's why I asked Dr. Grudeva, if the patient has already necrosis, there is no much point of doing revascularization, at least endovascular, because one way or another the patient is going to get into the operating room for laparotomy. If the patient has only ischemia, I mean, if he's in the first 6 hours from the symptomatic, you have some endovascular options. You can do a PTA and put a stent, you can make thrombolysis, or you can make a suctional thrombectomy. Skip this slide. What are the findings? Most often we see embolics in the proximal 2 centimeters of the artery. Not very often in the small branches, because most of the time it's we talk about embolism in more of 70% of the cases. So the emboli stops in the first 2 centimeters of the artery. Dr. Grudeva described the changes in the bowels, so I will not repeat them for the sake of time. As I said, you have a few options. One option is thrombolysis. If you have a device that does a pulse thrombolysis, like the angiojet or some other device, there is some point of doing that. But if you want to do just a catheter-based thrombolysis, there is no much point of doing that, because with a bolus injection of TPA, you will get no benefit. You have to leave the catheter, you have to do thrombolysis at least 12 hours, and for 12 hours you will have a very, very large ischemic and necrotic bowels, and of course you cannot send the patient to abdominal surgery after that. So the thrombolysis, if you don't have a device, a machine that does it, there is no much point of doing that at all. You will only kill the patient. The other suitable option for endovascular treatment is suctional thrombectomy. The machine that we have and the machine that we use is the penumbra machine. It's nothing spectacular, it's just a suction machine that has a very large negative pressure and a few dedicated catheters that are very flexible on the shaft and very firm on the tip, because the suction of the penumbra is so strong that if you use not dedicated catheter like a coronary guiding catheter, sometimes the suction can actually squeeze the tip of the guiding catheter and actually you're not doing anything. You cannot suck any of the thrombus. I don't have any experience with the Rotarex. Probably it works too, but in the of course there is some pros and cons for every kind of procedure. The aspiration embolectomy or thrombectomy, whatever, I think it's the most suitable method. I say, in my opinion, the thrombolysis is not a very good method. Stenting, okay, but if it's not embolic, if it is in situ thrombosis and you have atherosclerotic plaque underneath, okay, you can stent, but in embolic, there is no much point of putting a stent there and will not resolve anything. And of course, you can send the patient to surgery. This is the guidelines. This is what we should do. If you have a suspicion clinical, you make an ultrasound, then you make a CT scan. If you have necrosis and peritonitis, you send the patient to surgery. If you don't have and you're in time, the first 6 hours is the best, you should do try to do revascularization of those patients. So one case, 85 years old male with arterial hypertension and atrial fibrillation with unknown onset, no anticoagulation, occur severe abdominal pain within 1 hour, and with the suspicion of acute aortic syndrome from another hospital. The patient was transferred to our hospital. No ultrasound. The CT scan, I don't have the images unfortunately, but the CT scan rules out dissection and observed occlusion of the superior mesenteric artery, and the duration after start of the complaint since 3.5 hours, 3.5 hours, so it's quite early, and we decided to do angiography C and try to do thrombus aspiration with the penumbra. This is the renal artery, and on the other side you see the catheter jumps into the SMA, and you see a very large embol in the proximal 2/3 of the artery. For the penumbra catheters, you have to use some guiding catheter to engage the vessel you want to do the procedure. Then you advance the dedicated catheter, which is this one. This is the Cat 6, and it has you see on the tip this ball that has a very let's say, strange name, a separator. So with this separator, you first disrupt the thrombus and then you clean the catheter so you can do continuous suction of the thrombus. On the other side, you see the result after the first suction. There is some flow in some branches. It's not enough. So we make a second run. It looks the same as a technique, but now we have a good flow in all the branches, and this is the final result. All the branches have a very good flow, very fast. Discharged on the second day, no data for bowel necrosis, stable hemodynamics, and rate control of AFib and anticoagulation, of course. The endovascular procedures have a good success rate, over 90%, but some studies say that they lower mortality compared to traditional therapy, and traditional therapy is surgery. Some patients, even with good reperfusion, need bowel resection. Some trials say that the extent of bowel resection is reduced by half if you have a good reperfusion before the operation. So there is a point of revascularization in the acute setting of acute mesenteric thrombosis, and of course, from the conclusions, I think the last one is the most important one. For every embolic or thrombotic event wherever in the arterial tree in the human body, time is the key to success. As early as you make the reperfusion, the better results you would have. Thank you for your attention.
Any questions from the audience?
I would like to ask you how you estimate residual part, stenotic part of mesenteric superior artery after thrombectomy, and with which medicine you protect another event.
Anticoagulation, because it's embolic event, it's the answer for prevention. And as you can see, those parts are most often spasm. They're not actual disease in most of the times. If the patient for the future has some complaints like postprandial angina, okay, you can have a second evaluation and do another CT scan or another angio, and you can treat them. But most of the times it's spasm of the small branches when you make the procedure.
Thank you.
Yeah, I have another question. So, in case if there are some suspicions for irreversible bowel ischemia and an emergency laparotomy is needed, would you go for endo first, or you refer the case to the surgeons for one-stage observative laparotomy and open thrombectomy?
I'll send the patient to surgery, but you have to have abdominal surgery and vascular surgery, and in one operation to do both revascularization of the artery and resection. Unfortunately, we have only vascular surgery. We don't have abdominal surgery. So if the patient has certainty of necrosis, I would transfer the patient to another center, another hospital that has both.